Wow, from all of you. I mean, first of all, I think the amount of thoughtfulness and action taken by this group is very impressive. But I do want to come back to the question of how to eat the elephant, right? You doing your share, you doing your share, you doing your share, you doing your share. How do we bring them all together to make it really effective? My biggest concern is Governor Baker is going to have great data from Massachusetts, but somewhere, some other state, maybe not so, right? And a lot of the discussion had to do with, yeah, we know, well, there are some things we know what we should do, right? Prescription, education, right, treatment, etc. I would like to ask, how do we bring them all together? Because you can do it in your state. What is the federal responsibility? What is the state responsibility? What is our responsibility, the medical profession and the health professions and others? So can you help me think about how, with all this tremendous energy going on, and maybe I turn to you first, Charlie, because you're on the President's Commission, you're also a state governor, and you know health. How do you bring the order? What's federal, what's local? And then, you know, you're able to say, look, you can't graduate from health professional school without passing or taking a test. What about all those people out here who are in charge of graduate medical education, medical school education, nursing education, pharmacy education? How do we bring it all together?
Well, that's actually one where I think the federal government could make it pretty comprehensive and pretty complete if they just basically incorporated pain management and opioid therapy as a core curriculum for anybody graduating from any school that's going to be prescribing. And I think that ought to be, as I said, for us it's not just a function of school, it's also a function of relicensure. You can't get relicensed if you're a prescriber without taking and passing a course. People ought to know, people ought to have access to whatever the next generation of thought leadership is on this. I also think the feds have an enormous role to play in trying to answer this question about what works and what doesn't and why. If you think about the history of most of the progress we've made in understanding how to fight and battle a whole variety of diseases, no one has access to both the talent and the resources that the feds do to take that one on. And I think in this particular case, that would be enormously important. I think the other thing, you know, I sort of poked the former secretary here a little bit. You know, the Medicaid waiver that we got made a really big difference. It dramatically expanded our ability to support both behavioral health and addiction services for people in Massachusetts, and that was absolutely a partnership between us and the federal government. Mm-hmm. But I think the biggest tool the feds have is its ability, because of the fact that it's the largest payer, the largest financer of research, the largest financer of graduate education. It has the capacity to influence all that stuff in a way that almost nobody else does. I also think you can incorporate some of the stuff that they have in research that they do that relates to trauma and to other issues like that, and make that available to states and create what I would call kind of a compendium of things that work and things that don't. States tend to do things differently, but they are, for the most part, interested in knowing what other people are doing that's working. And the feds, nobody has the capacity to collect, absorb, synthesize, analyze, and move information the way the feds do. Nobody.
Okay. Well, let's talk about prescription then. You have, Massachusetts has a limit of 7 days of initial prescription, right? CVS,
that went down really easy with everybody.
Yeah, well, that's what I was going to ask you.
Yeah.
CVS just came out and say, yeah, 5 days, is it?
No, they went with 7 days.
7 days, yeah. Right? And the independent Blue Cross Blue Shield Pennsylvania came out also with limit. So now we have all these activities, and, you know, where's the professional, you know, organizations that say, what are we going to be doing about this? So how do we bring that all together? And of course, Scott, you thought about this. You talk about packaging, right? So help me think about how this can come together that becomes standard. At the same time, we really have to be, you know, sensitive to patients' needs. You can't just simply say, that's all you're going to get, come back. And, so how do you actually know and sort out who needs more, who needs a larger prescription? How is it easy for them to get access to more pain drugs when they really have major pain, and those who don't need it? So,
well, I'd like to share a quick story, because when I was the state health officer of Indiana, we were having a debate over whether or not to adopt a statewide limit on acute prescriptions for opioids, similar to what Massachusetts did, what New York did, and got quite a bit of pushback from a lot of folks in the provider community. And one of the challenging things was that we started to look around at the different states who'd done it, and as you mentioned, some had 5, some had 7, some had 3. And the challenge is that we do know in some areas what works, and we need to promote those evidence-based best practices, but I think you're exactly right, Governor, that we also need to do more research, particularly on policy interventions, to determine if we're actually getting the results that we think we're going to get, and then try to get some standardization. One of the frustrations from providers, and that we're actually hearing pushback from patients on prescriber limits, is that, okay, well, I go into the pharmacy, and depending on which insurer I have, I may or may not get my prescription filled and may have to be sent back. And so policymakers are then starting to get pushback from their constituents about the lack of standardization, and then you end up getting laws that represent the frustration that the constituents have. So I couldn't agree with you more. I think it's both. I think you're both right. There is lots of stuff out there, lots of programs that we know work, and we aren't doing enough of them. And we've absolutely got to do better.
Well, it strikes me that, first of all, we have to have a dramatically increased sense of urgency. We don't have years to figure this out. So I think that's got to start. And it also strikes me that there are appropriate topics so the provider community, the doctor community, the prescribing community should step up and make recommendations like yesterday about appropriate numbers. Not lawmakers. Lawmakers in Kansas are very capable. I don't want them to necessarily be the ones setting guidelines, but it needs to happen quickly. I think states move much more nimbly than the federal government, and frankly, Congress doesn't move at all. And by the way, as a Democrat from Kansas, I'm allergic to elephants, so I don't eat elephants. Some other analogy maybe, but not that.
You don't even want to eat one?
Lifetime bad impact. But I know in a state like Kansas, 10 years ago, we changed sentencing laws in a very conservative state around people who were coming in with just drug use. Lined up different treatment strategies, made it so the judge is absolutely right. This needs to be, but states can do that fairly quickly. States can move fairly quickly if they have the parameters and the federal support on treatment options. I mean, you know where the gaps are in Massachusetts, which are different than the gaps that may exist in Kansas, different than Arkansas, but you need some help and support. You need some money, and you need some treatment options. So I think that the National Institutes of Health does not have an institute dealing with addiction and substance use directly.
It does.
They have, I know Nora, and I'm a huge fan, but it is not the directed, moneyed institute that others have the opportunity to have, and we heard that a lot from NIH people. I just think additional resources, additional talent, a real focus broadly on this issue. So I do think there are gaps that can be addressed. And frankly, I think we have to begin looking at the messaging. We, I think, have some agreement that this is a health crisis, not a criminal justice crisis. We have a new Attorney General who says just the opposite. We have some leadership currently who is not, I think, advertising or advocating evidence-based treatment. So some of this is a real mixed message at a time of great turmoil. And again, I think the doctor and medical community can play a hugely important role, cutting through some of the politics and bringing some of the science to the forefront.
Thank you, appreciate it. Scott?
I'll just echo that. I agree with you. I think that some limits on duration of use are an inevitability at this point, and I think the states that are more nimble and able to act more quickly have moved ahead on this issue. And I think it's incumbent upon all of us now to try to develop the evidence base to support what we're doing. We see the Pharmaceutical Trade Association supporting limits on duration of use. We see the supply chain imposing restrictions, and we see the states moving ahead. About 20 states, maybe more, now have limits on dispensing. I think in an optimal world, we would see the provider community starting to work with these bodies, and it'd probably be with federal bodies, and it could be with the FDA, and I hope it is with the FDA, to try to build the evidentiary base through expert guidelines that, as I mentioned, we can incorporate into labeling, and then it can become the basis for policymaking. I think that would be an optimal world. Now, we do see pushback from the provider community, to your point, about what this represents for intrusion and regulation of the practice of medicine. And this is an issue I've spent years lamenting, the growing federal regulation of aspects of the practice of medicine. But I would say that with respect to controlled substances in particular, it's different. And it's different because this is the one place where there has been a very long-standing explicit expression from Congress that Congress intended for there to be more regulation of the practice of medicine. I could think of no federal statute that is a clearer expression from Congress, and if I get the law wrong, please let me know. No statute that's a clearer expression from Congress that they intend for there to be regulation of aspects of how medicine is practiced in the Controlled Substances Act. So clearly, through the CSA, Congress intended for there to be limits on prescribing through the scheduling process, through the limits on re-prescriptions imposed by the CSA. And so there's a clear congressional mandate already in place that Congress intended for us to be more diligent in how we dispense these products. And that doesn't mean that it flows naturally from the CSA to take these next steps, but it does mean that society has contemplated these questions and expressed a desire to make sure that, at least within the realm of controlled substances, there was greater regulation on what doctors did. Did I get it wrong?
By the way, on almost all the dispensing limits, they're all on first prescriptions.
Yeah, that's
okay. Right. They're not on every prescription. First prescription.
And IR drugs as well, which are, right.
But the goal there was to basically get away from people writing really big prescriptions for things that didn't justify or weren't appropriate for it. And when we proposed our 7-day limit on first prescriptions, the CDC recommendation was actually 3 days. And the conversation with the physician community and the legislature was about, sort of where should we land here. And frankly, the docs, the practicing docs, played an enormous role in getting that 7-day first prescription limit. The trade association kind of had one point of view at the beginning, but then they started hearing from their members, and their members were basically saying, this isn't a bad idea. In fact, it might be a good idea.
Steve, you said you're going to talk about actions. And by the way, we're ready for opening the floor to all of you, so please get ready. Yeah.
I truly believe that 80% of the solutions in the community, 20% is with the state and the federal government. And the state and the federal government's responsibility are what you're discussing, but also what they fund, how much they fund, and the involuntary laws both for substance abuse and mental health. But it really requires the community to come together to make the structural changes to help improve this situation. So for instance, when we started our project, which was more mental health, but I think it's a wonderful guide on what could be done on the substance use, I will say it is good to be judge, as the secretary knows, to have a husband. But
I don't have to stand up.
When we invite people to a meeting, they come even if they don't want to be there. And so we have wonderful moral authority with contempt power. And so 17 years ago, we literally invited all the non-traditional and traditional stakeholders that were involved in mental health issues. And we sat down. In the first half day, we literally mapped out how our criminal justice system intersected with our community mental health system. And what we realized in a half a day, it didn't take that long, is we were embarrassingly dysfunctional. I mean, you had to ask who's more sick, the person with the illness or the policy types that actually devised a system that is set up to fail. And so we realized we needed to take a two, and if I did it again, a three-part approach. We needed to have a pre-arrest and a post-arrest diversion system in place to help people access treatment. It's not rocket science. We trained 5,600 police officers in Miami-Dade County in a 40-hour training program how to identify people with serious mental illnesses, how to de-escalate, not to escalate and shoot, and where to take them as opposed to arresting them. We keep data on every single mental health call, my two largest agencies, at a 38 meg. The City of Miami and Miami-Dade, over the last 7 years combined, did 71,628 mental health calls. In that same period of time, they only made 138 arrests. My jail audit went from 117,000 arrests a year to 56,000 this year. So great that we closed a jail during one of the worst economic periods, literally, because this is usually cost shifting, not saving, but when you close the jail, it's a saving $12 million a year, which enabled my county to just give us $42 million, where we are now building the first of its kind, a one-stop shop forensic diversion facility for the most acutely ill that keep recycling through the systems. We also set up post-arrest diversion programs so that if somebody now comes in with a co-occurring disorder that has a serious mental illness, within 3 days on an arrest on a misdemeanor, they're out of jail, they're at a crisis unit. We set the case in 2 weeks because it's a criminal hold. The civil involuntary hospitalization laws don't apply. Gives them an actual time to help them get stable. So like the IMD needs to be adjusted, by the way, when you go back and see the secretary at HHS. Because 2-3 days at a facility is not enough time. They don't need months, but a couple weeks. Once they get stabilized, they're offered an opportunity to come into our program. If they say yes, which most of them do, we do not rebook them. We have 7 peers. They are the magic formula to this. These are 7 people with mental illnesses. 4 of them graduated from our program. They're waiting for them when they come out of jail. They have housing for them. They have their benefits lined up. They have clothes for them. They have transportation. They have their appointments. They have their medication ready for them. They eliminate all that fragmentation. The recidivism went from 72 to 20% of our misdemeanors. The state attorney is like, wow, this really does fight crime. Let's expand it to felony cases. We do the same thing with felonies. 70% of the people in the felony program successfully complete it, and only a 6% recidivism rate. And that program saved the county 68 years in jail bed days. And it was about accessing treatment and making it easier for the patient to get the services they need for recovery. And while, yes, I sat through a lot today and I understood about a third, but while we don't know everything that works, we do know enough that works well enough to at least get people on the road to recovery. And so getting them access and letting them know that there are other people that care about them that want to help them recover often is enough, without even knowing what the greatest science is, to help them get to where they need to be. They can't be alone, they need structure, and they need to know that other human beings care about their success. And our system is not warm and welcoming. And so we have to, and what we need your help to is to give recommendations to our communities. Every school, I have a kid in public school, although watching today, I think I may lock him up in his room till he's 21. He's 14. He had to get all kinds of tests and exams before he started public school. There's no such thing for if he had trauma or if he had any kind of mental health. Why aren't we doing that? That would have been the third thing we should have started 17 years ago. It should be the exact same thing to start school. And you talk about the doctors getting opiate and painkiller. I don't think that's enough. I think they need mental health knowledge, because they don't. Most people it takes 10 years to get a good bipolar diagnosis and 3 different doctors, because people go to a primary doctor, they don't go to a psychiatrist first. And so there needs to be these medical home models which I think will eliminate stigma even better, because people will be at a place that they feel safe. It's a doctor's office, not a psychiatrist. And I think these are the kinds of advancements that you can help us do in our community.
Thank you.
I had a quick point to that, Victor. I couldn't agree with you more. We've got to make it easier for folks to get help than it is for them to get high. And that's really what it comes down to. But another statement challenge to the audience, and it's the point you make about reaching out. Every one of you all in here has a superpower. As leaders, you have the superpower to convene. And we need to make sure we're convening the right folks, that we're bringing in those non-traditional partners and not continuing to speak in our echo chambers to the same folks over and over again, so that we can really harness the true power of the community and not just our subset of the community. I really implore you all to think about the non-traditional partners who should be at your table who aren't. The faith-based community is huge, in addition to law enforcement, in addition to the business community. The faith-based community is doing a lot of this work out there right now in terms of the social determinants and social supports that you mentioned that we know are key to folks. The housing community. If we define this as a public health issue or a medical issue, how many of you all would think to invite your director of housing to the conversation? The biggest indicator of whether or not you're going to be successful in terms of recovering when you get out of jail is whether or not you have a permanent supportive housing to go to. That's the biggest indicator. How many of you all are inviting those folks to the table? So I challenge you all to use your powers to convene to make sure we're reaching out to other non-traditional partners.
Thank you, Jerome. That actually has been part of a theme of this morning's, at least my remarks, plus many of the activities we do. But let me just take short questions because time is late. There was such good conversation, I didn't want to cut them off. So by definition, you're allowed a very short question, else I cut you off.
Good luck with that.
Good luck with that, okay.
No, I have a question. Charles O'Brien, University of Pennsylvania. I have a question for Governor Baker because I've been working on this problem for many years. How do we get addiction into medical schools? It turns out that the medical school faculty actually don't like addicts, or very few of them do. And I've given my videotapes of our lectures and syllabus, and even very important, the final exam on addiction. It's not just opiate addiction. You know, we give them the whole course, and we teach them how to treat pain. And the Penn students give us teaching awards, but I haven't been successful with, except for a few other medical schools. Maybe some of the deans of medical schools in the audience can tell me what I'm doing wrong. I even went to the American Association of Medical Colleges because I have noticed this at my colleagues all over the country that there are very few schools, maybe Massachusetts.
We got the message. Thank you. Really.
Okay.
Short answer.
Look, I mean, the good news here, to the extent there is some, is we have 4 medical schools, and they all signed up to do this almost immediately. And I think they signed up in part because we made it a big-time public issue, and we had them into my office, and we said, you have a big role to play in helping us deal with this, and we expect you to step up. And they did. And I think, I think the only way to make this work, to follow up on both of your points, I mean, the community's got to want to play, and people have to decide that they own a piece of the responsibility for dealing with this.
Last point, just do some quality control, because they may promise it, but it's not really there.
We got it. Thank you.
Hi.
Short question.
Deborah Prothro-Stith from Charles Drew University in Los Angeles. My question is about innovations in addiction treatment. Opioid addiction is intractable, and it's important to talk about how to prevent the epidemic from becoming more, but we have a lot of addicted people in primary care physicians' offices. I happen to know one who's 100 years old, who, because of the restrictions on prescriptions, is having trouble getting the medicine that she's addicted to. And we are not good in medicine on addiction, but if we're going to treat this as a medical problem, I think we really have to ask the question, where's the innovation in treatment? Because we really aren't that good at it.
Look, I think it's absolutely an important goal that we help more people live lives of sobriety. We have three approved treatments for opioid addiction. They all work. One is a full agonist, one's a partial agonist, and one's an antagonist. I think we need a treatment setting that allows people, when they present needing treatment, treatment is selected based on what is optimal for their circumstance and not necessarily selected on the basis of where they presented. And I think too often in the provider setting, if you are offered treatment at all, and many people aren't offered treatment at the right time, you're offered treatment based on where you present because one treatment facility versus another only offers one alternative. So I think that's a challenge. There's a challenge in the provider community. And I think to your point, there's also a challenge in making sure that we have a wider variety of treatments, both agonists and antagonists, and longer acting formulations as well. And so we're going to be trying to articulate very soon, we're putting out a guidance document, which is how we articulate regulatory policies to try to provide a clearer path to product developers on how they can innovate in the kinds of treatments that are available to patients, because that is absolutely a vital goal. We have to solve the new addiction problem, but we have a very large number of people who are currently addicted that we have to help them live lives of sobriety.
Thank you. Short question.
Excellent panel and discussion. My name's Myron Alukian from Boston, Mass. You can see, great job, Charlie. You can see why we are so proud of our governor and our public health commissioner in Massachusetts. The United States is essentially a take-a-pill culture. Part of the reason for that, in my mind, is we are one of the few countries in the world that allows the pharmaceutical industry to advertise directly to the public. We also have an industry that is very strong in Congress, the way they control Part D of Medicare, to prohibit bulk purchasing by the federal government, so we have to pay higher prices for medication. What does the panel see as the role and responsibility of the pharmaceutical industry to help us with this opioid crisis and this pill culture that we have in our country?
Well, let me turn that around, because you mentioned the pill culture, and that's a perfect follow-up to the last question. Too often when we think of non-opioid, we're still thinking of pharmaceutical. We need to do more research and more promotion of non-pharmaceutical alternatives to opioids, such as music therapy, such as physical therapy, such as acupuncture, such as some of the other non-pill, because as you mentioned, we are a take-a-pill culture, and okay, well, this pill isn't working, so let's come up with a new pill. You're constipated from your opioids, we've got a pill for that now. How do we adjust our thinking completely so that everyone doesn't think that they need a pill to solve whichever problem du jour we're facing?
Okay, thank you, Jerome. Scott or Kathleen, you want to take that question earlier?
Thoughts that may be different than yours.
Well, I think we all have an important role to play, including the pharmaceutical industry, and FDA certainly has a role to play to make sure that that the activities of the pharmaceutical industry are appropriate in this space, and that, especially with respect to promotion. And the promotion in this category has changed a lot over the years. There were allegations of promotional activity in the past that crossed lines. There were warning letters issued. There were sanctions issued. The tenor of the promotion has changed a lot in more recent years, and we are very vigilant, particularly with respect to this space. But to get at the sort of underlying issue of promotion as a factor in commerce and in the practice of medicine, it is the case that promotion generally is constitutionally protected commercial speech, and I think there's a very important role for FDA to play to make sure that it's delivering a proper public health message, and that's what our regulations are intended to do.
Kathleen?
Well, and I think that I would hope that the pharma industry also steps up as part of this solution and supportive of some of the limitations we're talking about. I know that there are a whole host of state attorneys general who are looking at the legal system to deal with some of the what they see as pharmaceutical abuses in the past. I think Congress needs to continue to be urged to look at some limitations in this area, but the pharma industry and particular companies have not only been responsible for a lot of advances that have saved people's lives and cured a lot of illnesses, but they also have some responsibility for overselling, over-promising, particularly in the opioid area, where the early promises were they weren't addictive. So we've got some real issues, I think, that need to be dealt with.
I'll just add as an addendum, the biggest problem, or one of the biggest aspects of this challenge, is the immediate release formulations of these drugs, which are very cheap, very widely available, not heavily promoted because they're all generic. And so I think the scope of this problem is so enormous, it's gotten beyond some of the issues that in the early years instigated the problem, if you will.
I'm going to limit to the last 4 questions. Cato?
Yeah, hi, I'm Cato Lorenzen from the University of Connecticut. I'm actually a practicing orthopedic surgeon, also an engineer, and I'm the editor of the Journal of Racial and Ethnic Health Disparities. So my question is, I'd like to see whether people will take a bite out of the elephant in the room. And to me, the elephant in the room is the white-black difference that's taking place in how we're viewing the use of drugs or the illegal use of drugs. You know, and in this world, we have whites who are given recovery managers, while blacks are being given parole officers. And we have in this country, we've medicalized the opioid and called it an epidemic and a condition, while we've criminalized drug use by blacks. And so, so where do we move from here, and how do we correct the faults of the past, making sure that it's an epidemic, and make sure that we find ways to create the treatment paradigms that work for all people, not just for whites?
So I guess what I would say is that the more we can frame this as an issue that's a public health issue and a healthcare issue, the more likely it is to be dealt with in an appropriate way. I mean, Massachusetts has, depending upon whose study you look at, either the lowest or the second lowest incarceration rate in the country. Our arrests and our crime and our prison population are all falling at the same time, even though we have the lowest in the country.
You're welcome. We gave you $52 billion in Medicaid from Florida, so.
Take yours.
Go there, buddy, because now you're getting into my world, okay?
Yeah.
But I think
Scott.
I think the point you raise is a good one, and I hope we learn from our mistakes, and I hope we handle this one the way we ought to handle it, which is to focus on the issue at hand, which is people trying to fight their way out of an addiction and supporting them on that. But his larger point is right.
But I also think there has to be some serious legal changes.
Yeah.
For instance, crack cocaine has much higher sentencing than powder cocaine. And so there's structural problems that the governors, the states need to go back and undo some of those inequities, because the crack falls much heavily on African American communities than powder cocaine. There's no difference in the drug, and it's really a discriminatory offense. So the doctor is 1,000% right. We see it every day. It is offensive to us, and our hands get tied because we have to follow those laws, and there's sentencing guidelines that give people greater sentences based on the different types of drugs that the individual's been caught with.
And again, I think the faster we move to sentencing change, states can do it more quickly, but it needs to be addiction writ large. It needs to look at the disparities, heroin versus opioid. I mean, we have lots of discriminatory sentencing practices that are baked into criminal justice, and I think a lot of states can move much more expeditiously at addressing that. But you're absolutely right. This is an addiction issue, not an opioid issue.
But you've got to have the churches and the law enforcement officials, particularly in the minority communities, at the table when you're having these larger discussions, so that they can share that same perspective, that elephant that's in this room that you brought up. So thank you for that point.
Thank you, Cato. Short question.
My name is George Hill from Vanderbilt University in Nashville. The Surgeon General mentioned earlier the importance of communication, and that we had to communicate in an effective way in order to address the problem. So my question actually deals with examples, or an example, perhaps from members of the panel, on what has been an effective way to communicate what we've talked about today to decision makers or to individuals out in the community who can really make a difference. Can any of you think and share an example that would be something that could be replicated, or it is being replicated, Thank you.
I think one of the biggest things is this whole stigma question. I mean, I can't tell you how many people I talk to for whom that is an issue. And it affects people's willingness to come into treatment. It affects people's willingness to acknowledge they have a problem. It affects almost every element of this. And I think it's incumbent on all of us, and especially those of us who are either connected to the healthcare world or the public policy world, or the, you know, I would add the criminal justice community as well, to treat this and talk about it as an illness to be dealt with and not as a character flaw.
But I think there's also a stigma among physicians that don't want to deal with people with criminal justice involvement.
Or addiction problems.
Or addiction problems. And so that is contributing. I think we all, and I think what it requires are these collaboratives in the communities to bring all those parties together and figure out how we're going to address these issues, because it is a huge problem.
I can give you a very poignant real-world example related to what we're talking about. In Indiana, syringe service programs were illegal, and we had to figure out how to halt transmission of disease in the largest HIV outbreak related to prescription drug use in the United States history. We brought in scientists, we brought in the CDC to try to convince policymakers, and at the end of the day, then Governor Pence, now Vice President Pence, went down, called me up, and we went down to the county, to Scott County, to have a discussion, and the sheriff, who's a former Navy SEAL, showed up, the business community and local pharmacies showed up, and they all said, we think we need this as part of a solution, and that's what really turned the tide. It wasn't the medical experts. You needed the science there, but it wasn't the medical experts that changed the minds and hearts of the people in the community. It was the business folks and the law enforcement folks. If you look at Gallup polls, what people vote on, the number one issue Democrats and Republicans vote on is the economy. Number two issue that they vote on most frequently, that most bubbles up, is safety and security. You need the law enforcement and business communities at the table, and you're not going to convince them with all the data in the world if you don't have the support of those other two entities.
Thank you, Jerome.
I would also say that the flip works, I think, very well also. What the judge talked about and what I've seen in a local legislator hearing is some data about what doesn't work, how much it costs, and the fact that it's a total abject failure. And when you get agreement around that, people are interested in then what can work, what is next, and having some of these models, I think, whether it's the Massachusetts model or the Miami-Dade model or the change of sentencing laws or a variety of things, knowing that what we've done absolutely has failed miserably for decades is really important and costs a whole lot of money.
Okay, Anissa, you have the last question.
Okay, Anissa Abdidargham from Stony Brook University. I was appalled by the statistics that Judge Steve Leifman provided us about the rate of severe mental illness in prisons. And I think anywhere in the world this would be considered a violation of the human rights of these patients. And I think this calls, thank you, it really calls for a big action, not small bites of an elephant. It needs to go to the highest level of attention, to the White House, to whoever are the policy makers. It needs a quick solution. One quick solution may be to transform the prisons into hospitals, but I don't know if that's feasible. But this is just incredible, and I just wanted to make this point and get your thoughts.
There is a national movement we started about a year ago. It's called Stepping Up. You can Google it, and I hope you would become part of it. It is a collaboration between the National Association of Counties, the Council of State Governments, the American Psychiatric Association Foundation, working in conjunction with the Justice Department, the Sheriff's Association, and NAMI. And it's to reduce the overrepresentation of people with mental illnesses in the criminal justice system. And we're going around the states right now, we're going to communities, we're teaching people how to do diversion, how to access treatment, what it should look like, what works, what doesn't work. But we need more of the physician community to be part of this initiative.
And so Scott and I don't get fired. I think it's important that you all understand that HHS has 3 clinical priorities right now. Number 1 is the opioid epidemic, number 2 is youth obesity, and number 3 is serious mental illness. So when you talk about being very intentional and taking a bite of that apple. HHS is the biggest federal agency, and of the top 3 priorities, 2 of them are related to everything we're discussing today. So we've been challenged to take a big bite out of this, to be innovative, to think about it. But as the judge mentioned, our job at the federal level is to lower barriers and facilitate local solutions, but the solution, again, is in the cities, in the counties, in the mayor's offices, in the states. It's really going to take all of us coming together, in addition to the work we're doing at HHS and in concert with the administration to solve this difficult issue. So thank you for that question.
Thank you, Jerome. So before I thank this distinguished panel, and I know they came because they had reason to come despite their busy schedule, that is talking to us, the Academy. So here's what I heard. Urgency. We have to play our role, right? Because the message is very clear. If we don't do what we're supposed to do, it's not going to work, and we don't want to drag around along with it. So I would say all of us need to commit to making a difference, whether you're educators, practitioners, policymakers, researchers. So I want to really thank this outstanding panel for getting us to this place. Thank you. Thank you. That's terrific. It's good to see you too. Oh, so wonderful. Thank you.
You bet.
Thank you. Yeah.